So welcome to the webinar, Find Joy in the Journey, Contemporary Denture Workflows. It is being presented by Wendy A. Clark, DDS, MS, and we're going to begin shortly. And with that, it is my pleasure to introduce Dr. Wendy Clark. She is an associate professor of prosthodontics at UNC Adams School of Dentistry. Dr. Clark completed her undergraduate training at the University of Georgia and earned her doctoral degree from Marquette University School of Dentistry. She then earned her master's degree in clinical dentistry and certificate in postgraduate prosthodontics from the University of Alabama at Birmingham School of Dentistry. Dr. Clark practiced prosthodontics for 7 years with Team Atlanta and lectured nationally on a variety of topics ranging from smoking cessation to dental implants. She was named a leader in continuing education by Dentistry Today in 2017. Currently, Dr. Clark is full-time faculty at UNC Chapel Hill Department of Prosthodontics. And it is now my pleasure to say, take it away, Dr. Clark.
Thank you, as always, Jessica. I appreciate the warm welcome. And today I will be talking about digital dentures, and I do speak on behalf of many companies, including Evident Digital Dentures, Dentsply Sirona, TrueDent Stratasys, and 3PX Software. None of those companies are sponsoring me today, nor is anybody else. So if I mention a project, a product, or a project, it is just for educational and demonstration purposes. So I was so excited when I found out that my denture class was going to be mentioned in one of the newsletters from the university. And the date came out, I woke up, I opened my phone. I know you're not supposed to read your phone first thing in the morning, but I did. And it described dentures as relatively unexciting and unprepossessing. And I don't know how you are before a cup of coffee, but I Googled, what does unprepossessing mean? I asked Siri, and I found all of these words. And I was so sad that these are the words being used to describe my very favorite topic of complete dentures. I've never described any of my dentures as grotesque or repulsive or loathsome. But they are not the only people that have that perception of complete dentures. And one of the favorite stories I've come across as I've been working with dentures over the last several years is that in 1962, at the World's Fair, they were going to bury a time capsule and open it in the year 2000. And they put in all the articles they thought that we would never use again in society. And they included a typewriter, which, great job, citizens. A phone book, again, that's really great. An umbrella, which I still don't understand, and a set of complete dentures. And then they probably unearthed those in 2000. Saddens that we still use complete dentures today. And again, not just citizens, not just people at the outside of the field of dentistry, but even dentists still kind of question the validity of complete dentures as a treatment. In 2002, this is right around the time I was starting dental school, there had been multiple studies of populations to see the need for complete dentures. Everyone thought that people were going to keep their teeth longer, they would be replaced by implants, and that complete dentures would become a relic of dentistry. They did, again, found several studies saying that although the population, the percentage of the population that's edentulous has decreased, because people are living longer and because just life over the lifetime, people are having higher expectations, that the absolute number of edentulous patients has not gone down. So the percentage has gone down, but the population has increased. And so the actual number of edentulous patients is relatively consistent. And beyond that, they were questioning whether or not we even need to teach complete dentures anymore, which again, find this totally fascinating in history. There was a big movement, not only in the United States, but also in Europe, where there are lots of evidence in the literature and different reports where they were discussing, should complete dentures be removed from undergraduate or DDS curriculum and moved only into graduate prosthodontic curriculum. And I'm grateful that they didn't, and I think we all should be, because there's no way that prosthodontists alone could serve the edentulous population today. Fortunately, things are changing. And today, not only has complete dentures kind of solidified its place in most pre-dental curriculums, but also now digital dentures have become more commonplace. This article came out in 2021. It gives me much better vibes, to quote one of my my children. It has good vibes. That now we've accepted the fact that complete dentures are a necessity. Edentulism is not going anywhere, but perhaps digital workflows can help validate this subject and help treat more people. And this is a really great paper, and they basically say yes. And it's reflected in today's current curricula. In 2016, there was a study published through University of Florida. And what they found at that time was that about 12% of DDS programs were teaching digital dentures to their pre-doctoral students, their dental students, not their graduate students, but their dental students. And this is not overwhelmingly shocking. Digital dentures became commercially available to clinicians in 2012. So it takes a while for things to get well adopted into dental school curricula, as you probably all remember. So 4 years, not too shocking that not a lot of dental students had embraced that yet. I'm going to take a minute, and I want everybody to imagine what number are learning digital dentures today. And usually if I have people talking back to me, I hear 20%, 25%, maybe 50, 60% if you are in a more digitally relevant area. We ran a study. I was so excited to be a part of my colleagues from the American College of Prosthodontists of all the pre-doctoral and postdoctoral programs in the United States right now. 88% of dental students are learning about digital dentures today. And this to me is phenomenal. So almost 90% of dental students are getting this as part of their undergraduate DDS curriculum. So this is not grad pros, this is dental students today. And I think this is showing kind of the landscape of dentistry is changing, and certainly of removable prosthodontics as well. So I think this is great. So I'm glad you're here so that you can learn with a dental student. When I picked up digital dentures, I started working with them in 2013. I'm certainly not an innovator. I'd say I'm an enthusiast. So I would be more in the early adopter category. I think today now we've gotten solidly into this early majority. It's amazing the reception that I get now when I talk to people about digital dentures in 2024 versus when I was speaking on digital dentures in 2014. The questions have changed, the concepts have changed, the understanding and acceptance has changed. So I think this is really exciting and such a timely topic for 2024. So I did a presentation about a month ago that kind of the introduction to digital dentures. This will piggyback off of that, but if you didn't attend that one, that's just fine. I'm going to pick you up right now. So if you haven't learned about digital dentures yet, where do you start? You'll start with CE, such as this, and there's many, many other opportunities online and in person today. But all digital denture workflows fall, every step falls into one of three buckets. So, and this applies to Crown and Bridge also. So if you're learning digital dentistry, you're kind of new to the subject, any step you're on will either be acquiring data. So if you're doing a crown, it could be a scan. If you're doing implant planning, it might be a CBCT. It could be a digital photograph. It could just be a digital x-ray. But you're pulling all this information about your patient in the acquisition phase. You take all of that data, pull it into your software. So this is going to be the CAD part of CAD/CAM, computer aided design. And then all that data that goes into the design leads to something that's fabricated. So fabrication will be the CAM part, computer aided manufacturing of CAD/CAM. For dentures, it's going to look something like this. You might do an intraoral scan. You might do a conventional impression. You're going to pull all that information into the design software, do your virtual tooth arrangement, and then that gets converted to your digital denture. This will be PTSD for everybody that has ever taken a complete denture course. In dental school, this is still the method that we teach today. Oddly, this is the same technique that was taught in 1920s. So 100 years at least, we've been teaching this workflow, going from preliminary to final impression to wax rim to tooth try to insertion. Most dental schools are still teaching conventional side by side with digital. Digital dentures have not yet overtaken conventional completely. So even at UNC, where we've been teaching digital dentures for 5 years, we still teach side by side, digital and conventional. Digital dentures looks like this. You still have to get your impression, you still have to get your records, but everything's been consolidated a little bit. So that jaw relationship where you're measuring vertical dimension and centric relation gets combined with either the impressions or the try-in, and we'll go through many, many workflows today to show you where that goes. And to reiterate, we have to get our impressions. The try-in can be optional depending on the workflow you choose, and then we roll into the insertion. Impressions can be alginate, can be a scan, can be a custom tray. We'll go through all these different try-ins for the workflows. Monolithic is the one we're going to focus on the most. And last but not least, we'll talk about different materials that are available today in 2024. When we look at digital fabrication, you have two different options. One will be subtractive manufacturing, which is often referred to as milling. And the second, which is growing in popularity, will be printing or additive manufacturing. So when your patient comes in and needs a denture, there's all different things there's all different ways you can go, whether it's conventional or digital. And this is something that I've been working on developing. I love any feedback if it's helpful or not helpful, but doing kind of a decision tree on where do you go when your patient needs teeth. And so if they have a dent, do they have teeth? Yes or no? Easy question, right? And so then we have an immediate denture decision tree that we'll walk through later in the presentation. But we're going to start over here if our patient has teeth. And if your patient has teeth, did they come in with a denture? One of my colleagues that works at a DSO said that they found that about 80 to 90% of patients that need dentures already have a denture. So basically what that means is you're almost always starting with some sort of information. If they have an existing denture, whether it's good or bad, you can utilize that information. So for that majority of the population, if your patient has a denture, do you want to make changes? Yes or no? If you don't want to make changes, you're going to go through a reference denture workflow. We'll focus a lot on this. If they love it, then you'll use a copy denture workflow. So let's talk first about reference denture. When your patient comes in and they have a denture, I don't know how many people have done lab work for complete dentures lately, but one of the hardest things in the world is to take a patient's existing denture and copy it. And it's been such a painful process for me. I did a lot of my own lab work when I was in private practice, and we did all our own lab work in residency. So I've had to make many, many dentures. And the most frustrating thing, you'll have a patient's denture, you make all these little jigs and you try to reposition the teeth and make everything match, and it's never perfect. And this article validated my experience. I'm happy to not be alone. This article from British Dental Journal, the people doing the study took a complete denture and mailed it to 12 different laboratories, 12 different dental technicians, and said, copy this, like make an exact copy of this. Exactly 0 of them were an exact copy. And they have all these different criteria, whether they had frostbite, maintain the diastema, but not a single lab tech, excellent lab techs, none of them could make an exact duplicate of this patient's denture. And it's hard. Like, I feel them. I feel all 12 of those laboratory technicians in my soul, because it's such a challenge to try to do this. And patients perceive everything that's a little bit off. Fortunately now with digital dentistry, we can utilize the patient's records. We can utilize AI and algorithms to match the teeth almost exactly. And this is something we've never been able to do before. So if you're a dental laboratory technician or working with a dental laboratory technician, for me, this is a no-brainer where you should start with a digital denture workflow. So if you're a technician and you're saying, I don't know which workflow to start with, it's reference denture all day, because it will make your job so much more predictable. So again, the patient may love it and they want it exactly, from the occlusion to the aesthetics to the way that the intaglio feels, or they may hate it and they want to change everything about it. Either way, you have all this information that can save you so much time and so much struggle through the try-in process. So if they want to keep it the same, you take that denture, you put it in an intraoral scanner, a benchtop scanner, or you use your wand scanner, and you scan the entire thing 360 degrees. that data gets put into your software and an exact copy can be fabricated, which is so exciting. So if you have a denture that you like, the workflow in most of the softwares is called a copy denture workflow. You take it, scan it, copy it. It's like putting it in a Xerox machine, a little bit more nuanced than that, but the general idea, you copy it 360 degrees and make that patient a replica denture. The reference denture is a little bit more complex because we're going to want to make some changes. And I say whether the denture is excellent or whether the denture is terrible, it can always serve as a good reference. So let's walk through that workflow. And what we're going to do is evaluate the denture, feed it in the patient's mouth and say, what do we like? What don't we like? See if the base is overextended, underextended, and we'll start there. So if the base is very underextended or very poor fit, you'll want to do a true border molding with a heavy body material or green stick compound. You can truly use whatever material you use for your current complete denture workflows or your crown and bridge impressions if you're not doing a lot of removable. And you'll use the patient's denture as a custom tray. And if you think about it, this is one of the best fitting custom trays you can get, and it's already in your hand. Because this is a patient's current denture and we want to send them home with it, we're not going to do anything irreversible. So we're going to paint some tray adhesive. My $2 tip is that that tray adhesive will come off with a little bit of alcohol and a 2x2. It does not come off easily. Co-soft or co-comfort or Linol, any of those soft liners. So that is the one exception. I had a student find that out for me the hard way. But on denture base resin, if it's just a regularly processed or printed or milled denture, the adhesive will come off of it with alcohol and a 2x2. And if you're going to border mold, you paint just the borders first, go through the border molding process. And then after that, you paint the rest of the denture with tray adhesive on the intaglio surface, load it with whatever impression material you use for your regular impressions. In this case, we use the light viscosity PVS. You can certainly use polyether, you can use polysulfide, any material you're currently using. Light body, extra light body, monophase, all of them can be utilized well. But you'll notice this is a border molded impression inside a denture that looks like a denture. So it's important that you capture all that anatomy that you learned about in dental school, that you can see the frena, you can see the ridge, you can see the retromolar pad. All of that's still valid, even though it's digital. So recreation of anatomy is so important for a well-adapted fit. After you've done border molding, you'll take your interocclusal record and you want to get the bite as close as you can to vertical dimension. Again, if you're working with a patient's existing denture, it's going to be a little harder to close the vertical if needed, but you still need to measure it and figure out open and close and all that. The important takeaway here is that we're doing the impressions first, and then we're taking our interocclusal record. And this will go across all of the workflows we show. And this is such an important tidbit. If you're working with removable, even if you're working with conventional removable, you always want to wash and stabilize the bases first before you do your bite. Because every time you do a reline, it shifts that denture just a little bit, and it doesn't take much to throw off your occlusion. So do your reline first, then you measure your vertical dimension, then you take your centric relation record. And then you take your full face photograph. So when I first started teaching digital dentures, I got a lot of questions about the face bow information. And with the current softwares, especially the full service software, so the more common ones that you'll hear in dental laboratories, full service dental labs, you can actually take this patient's full face photo and pull it into the design software. So you may have seen digital smile design if you're working with implants or veneers or crown and bridge. That same digital smile design can be done for your denture patients, which is so awesome. So you want to get a full face photo, patient looking straight ahead at the camera, and you want to see their ears. So you want to see their face looking forward and see both of their ears. If you cut off their forehead, you'll survive. If they tilt their head this way, side to side, it's okay, but you don't want them to turn and look in either direction. You want it to be full facing forward. So head cocked is okay, but head turned will throw off your proportions of your teeth. So reiterate, I know I said this, I'm gonna say this like 6 more times in this lecture. Get your impressions first before you take your measurements, because that vertical dimension will change even slightly, and that can throw off your occlusion significantly. So impressions first, then records. And we need to get all this information for any prosthesis we do, whether it's full arch implant, whether it's complete denture, whether it's conventional, whether it's digital. You need your vertical dimension. You need your horizontal record, which is going to be centric relation most of the time with complete dentures, and an orientation record. For conventional complete dentures, orientation record is a face bow. For digital dentures, it's going to be that full face photo. And one of my colleagues said that this is where we jump basically from conventional to digital. And he describes this as the secret sauce of digital dentures. And it's digitizing the records. So you've taken all these physical bites, physical impressions, you've taken this photo, now that's your acquisition of data. Now we're taking that into the CAD software and digitizing everything. This can be done with a wand scanner. If you have any intraoral scanner, you can use Medit, 3Shape, Dentfly, Shining. They all work so well now. The softwares have all become so good with removable workflows. You want to make sure you're scanning the entire intaglio. The impression that you just took needs to be digitized. You want to see the gum line of the teeth. That's how the bite scan will become the most predictable. And you want to get the occlusal surface. So you want to see the occlusal plane, interocclusal record, and the wash impression. So you can do that in a number of different ways. A benchtop scanner is usually the fastest. A benchtop scan takes about 5 minutes or less, depending on the scanner you have. And most full service labs have these. And this is important to note because let's say you don't have a scanner in your office. It's still, not everybody has them today. And so if you don't have an intraoral scanner in-house, you still can make a digital denture. If you partner with a dental laboratory that has a benchtop scanner, they can take your records, scan them, give them right back to you. You could give them to your patient. So if you have a lab that's local that does pickups and drop-offs same day, this might be an excellent option for you if you don't have a scanner. The second option is going to be an intraoral scanner. And again, you can use any intraoral scanner you want, it doesn't matter. They all have capabilities now. If there's not a removable setting on your scanner, you'll use whatever the equivalent is of like a scan only or a generic scan. So whatever you would use to scan like diagnostic casts, you can use, and you just scan everything and scan all the surface on your denture. This takes a little bit longer than a benchtop scanner. It's a little bit more technique sensitive. However, again, the scanner softwares are getting better and better and better, and it's getting easier and easier and easier, which is lovely. The newest way that you can do this is with a CBCT scan. And there's only a few softwares available to my knowledge right now, but you can take that whole complex, the impression, the interocclusal record, put it in the CT scan, that gets scanned in and converted immediately to an STL. And that's important to note that no matter which way you go, whether it's a CBCT, a benchtop scanner, or an intraoral scanner, they're all coming to the same data. Every single method you use is going to end up right here with this intraoral or with this topographic scan of the intaglio, the occlusion, and the tooth position. And most softwares export it as an STL, which is basically a 3D file made out of triangles. There's all sorts of other 3D files. So some might use a PLY or a DICOM, but essentially this is what you're going to get. And they all can output the same information. Once you have everything designed in that CAD portion, if you're not doing the design yourself, if you're working with a partner or laboratory, it's so critical to request a digital preview. And I say this to technicians or assistants or clinicians in the audience, that the digital preview is the key for that communication back and forth. And if you're just getting into digital dentures, learning the software is sometimes the hardest part or the biggest hurdle to overcome. So if you can understand the workflow, partner with a laboratory that's already adept in this, it can make your journey into the digital denture world so much easier and so much more streamlined. And The digital preview is the way that we say, okay, this is what I want. Can you make this change? And the way that they can make sure that they're understanding what we're asking and that they're hearing what we're saying. So a digital preview, they're going to give you a setup of what they're proposing, and we'll show some few examples of that. If you've not done a lot of digital previews, this article that came out of Loma Linda University is outstanding. And this team put together a whole checklist of how you read a digital preview. So if you look up Goodacre, Journal of Prosthetic Dentistry, they have this really fantastic checklist, step-by-step, how you look at a digital preview. And once you've approved the design, the next step is going to be this monolithic try-in. A monolithic try-in is a 3D printed version of the proposed denture setup. And it can be printed in any color, depending on the printer you have, the resin you have, and what you're trying to accomplish. So there are some FDA cleared try-in resins that come in the most common denture try-in shades. So A1, A2, bleach white, the B shade. They don't have every single denture tooth shade, but the most common ones are available. If you're printing this in-house, you can use really any resin you have handy. So I've printed them in Carolina blue, in purple, whatever color that we need, because really we're using these as record bases and rims. So aside from the digital setup, I think that this is the next biggest hurdle for clinicians to overcome, is how to do the monolithic try-in. Fortunately, there's another checklist for that. This is a checklist that you can download online. The QR code should take you to the website. And it was developed in part by Valerie McMillan, who's a prosthodontist in Ohio. And she came up with a step-by-step. Does it have good retention? Is the vertical dimension correct? Are there overextended areas? Where's the midline? So super easy yes or no questions. And they walk you through the workflow of how you do a monolithic try-in. And one of the issues that I've had trying to train both students and faculty and general dentists is to not be afraid to grind like crazy on these things. This is just a prototype. And I think this comes from when we're learning conventional dentures. When you do your wax tooth try-in, those are your final denture teeth. And so if you grind on a conventional denture tooth, you're compromising the final denture product. That's not so with digital dentures. This is a prototype that's going to be totally refabricated. So the best thing I can compare it to is when you do a prototype for an all-on-X. If that doesn't fit, then you cut it up, you grind it, you lute it together, you do whatever you need to do to get to the next step. That's the same thing with these monolithic try-ins. So these are two different cases where the vertical was off only about 10 millimeters. So, a little bit here or there. And you can see the one on the left, we ended up grinding down to where we wanted the incisal edge to be. And you can see the difference. I mean, that's a pretty big deal. And not only that, we actually carved in where we want the cervical line to be. So now when the laboratory gets this back, they can see where I want the incisal edge and where the patient's high lip line is. And they have so much more information than me sending it back as is and say, move the teeth up 6 millimeters. So now when I get the digital preview back, I can make sure that the incisal edge on the proposed denture is in line with where we ground down that monolithic try-in. The case on the right, this was a monolithic try-in that again was about 10 centimeters off. And one of my colleagues actually had the great idea of taking this to the model trimmer and just flattened it down against there until they took it down that full centimeter and literally turned this into a wax rim. So when it's off, just treat it like a wax rim. Don't treat it like a wax tooth try-in, treat it like a wax rim. And in this case, you're probably going to want to do another monolithic try-in rather than going to final, unless your patient's in a hurry or you have some other reason to feel bold to go to final. No matter what kind of try-in you do, whether it's wax, monolithic, or anything else, you're going to want to achieve the exact same thing. We want to find the patient-centric relation, make sure that we had it correct in our initial bite. We want to make sure we nailed our vertical dimension, that we're not over open or over closed, that the patient is happy with the aesthetics, and that the function is good, that they can speak and that they have good retention in their denture base. Sometimes we'll do a 2-appointment workflow, and we'll go from that reference denture scan and bite all the way to the final denture. And so that's a 2-appointment. You do your wash, you do your bite, you do your scan. Next time you see the patient, you have their denture. The 3-appointment workflow, of course, you have your monolithic try-in, and then you go to final. When you make your final denture, we talked about the 2 different categories. We have subtractive and additive manufacturing. Subtractive manufacturing, or milling, there usually will mill the denture base. If you want and you like the look and the feel of a carded denture tooth, you can do a bonded workflow. And what that means is the denture base is milled, but you're actually bonding in regular carded denture teeth into the socket. Or you could do a monolithic monolithic final denture. The monolithic final denture has a custom-made puck for the patient where the denture tooth resin and the denture base resin are pre-polymerized together, and then they're milled out. And what that means is there are no individual denture teeth. So when you think about the most common complications of complete dentures, it's teeth debonding. So if you're looking for a stronger option for your patients, if they're debonding denture teeth or having fractures to the midline, a monolithic milled denture will give you the best physical properties. And there have been a lot of studies on milled dentures that have found that this to be very consistent. One of the other things to bear in mind is a milled denture, so not printed, but a milled denture is made out of polymethyl methacrylate, which is the same material as a processed denture. So if you're new to the field and you're concerned about having to learn new techniques for reline, rebase, repair, then milled dentures might be a great solution for you. Because everything is the same. You can reline them the same, rebase them the same, repair them the same, bond a tooth back in. Anything you need to do to a milled denture is identical to what you would do to a processed denture, except you're getting a stronger, more predictable, less porous resin. The more common one today that we're hearing more and more about is 3D printing. 3D printing or additive manufacturing is typically done in 2 stages. The vat resins, which are, or the vat printers, which is what we usually think about with 3D printing, can only print one color at a time. So you have to print your denture base, print your denture teeth, and bond them together. So they're made separately and then bonded together. 3D printed resins are not PMMA. They're a different type of acrylic-based polymer. So there's kind of some properties of composite since they're light cured, and then some properties of acrylics. And if we can go all the way back to the first printed denture I did in 2017. And I love showing this case. And I think it's even more impactful when I show it on Zoom versus when I show it in a big lecture hall, because you could really appreciate some of the details or lack thereof. And this they had FDA clearance of printed resin for intraoral use in 2015, and they became commercially available around 2017. So as soon as I found somebody that could print a denture for me, I did a printed denture as soon as they were FDA cleared. And this was the first denture I did, and I thought this thing was incredible. I was going through the hallways, showing this off, so impressed with the aesthetics. And looking back, just, I guess it's been 7 years now, 6 or 7 years. It's amazing how far we've come with additive manufacturing and 3D printing. So when I look at this today, I see, man, the resolution wasn't that great. You can see the print lines on the denture base. The resins were so translucent, and you can see the necks of the teeth. The teeth are not translucent, and they're about as opaque as my sink in my bathroom. They're so opaque white. And so now we have more translucency in the teeth. We have more translucency in the base, but opacifiers to hide the necks. We've learned so much more with the software where we don't just have this wall of teeth anymore. We have anatomy, we have a better library, and just the amount of growth we've seen in such a short period of time blows my mind. So I love this picture because you can really appreciate the detail that can go into a 3D printed denture. And so the picture on the right, you can see the stippling, you can see the imbrication lines, and you can see the developmental grooves that were designed in the denture teeth. All of that was done on the software and replicated with a 3D printer. So a 3D printer can reproduce things to a level of precision that no other workflows can. So right now, everything is kind of changing and growing and improving. The downside is we've only been doing 3D printed resins intraorally since 2017. So everybody asks how long they're going to last, and I have no idea. We've been through a ton of different failures, a ton of growth. We've been working with these for a lot for the last 5 or 6 years. And it's just, every time we start to learn the way a material behaves, then another version comes out. So the literature base is growing, needs to be developed a little bit more, but I certainly think the field is so promising and probably the future of dentures. The materials can be mixed and matched. You saw this a little bit with the first milled slide where there was a milled denture base and carded denture teeth. You can mix and match printing and milled also. Sometimes we'll print a base so that we can get a better adaptation of a really unique anatomy, but we mill the denture teeth because we know that they're going to have more predictable strength. So you can kind of mix and match whatever you and your laboratory technician feels the most appropriate for your practice. If you want to learn more about 3D printing, these are two outstanding narrative reviews. They both came out right about the same time. And they kind of go through the current state of 3D printing and where it's going. And they both came to the same conclusion that the ROI makes sense. You can print 20 dentures at a time versus milling one denture at a time. So this is so enticing for dental laboratories. But we don't know enough yet about the materials. So I think we're moving in the direction of printing, but it hasn't quite taken over 100% yet. If you want to learn more about the reference denture workflow that we just walked through, so the wash impression, the bite, and the scan, going to either the monolithic try-on or the final, this is a video that's about 10 minutes long, and it goes really in detail, more detail than I can go through on a 1-hour presentation. So if this is something you're interested in, this is a YouTube video. It'll take you right to it. Take a screenshot, grab a picture with your phone, and you can check it out later. It's a 10-minute video walking in detail through the reference denture workflow. So what if your patient comes in with nothing? Because there are still that 10 to 20% of the population that don't have a current denture, but they need something done. There's so many proprietary workflows that it would take me a full day, and I'm happy to do that later, where we can go through all the different types of workflows available. But the wax rim workflow kind of consolidates everything into a generic workflow that you can then customize for your practice. So this is my go-to workflow when my patient comes in with nothing. We take some sort of impression. I usually start with a scan. Sometimes I start with an alginate or an alginate substitute in a stock tray, depending on the day. And then from there, you can design your record based on wax rims. You go through the wash impression and a bite. We'll show some more pictures, monolithic try-on and final. So it's a 3 or 4 visit workflow. Certainly you can start with alginate substitute. This is just a metal stock Edentulous tray. Conventionally made wax rims, your light cure material and base plate wax, just like dental school. Or start with your intraoral scan. So you can scan your impression or you can scan the ridges. And there are lots of free softwares or paid softwares where you can take those scans and design either a custom tray or a record base. This one I did on Blender. This is usually the software that I'll work with. And I love it because I can make my relief wax however I want. So now you know I'm the geekiest prosthodontist. So I want to do a selective pressure impression. I put the relief wax around the mid-palatine suture and the anterior maxillary area. And then I print my rim in Carolina blue, of course, go heels. And then I just add a preformed arch of wax on there. So it says I scan intraorally, design in Blender, and print my record base and just stick on a wax rim. You can scan, send to your lab, and ask them to do this exact same thing if you don't have a printer in-house. From there, you will do your wash impression first. So always final impression first, no matter which workflow you're choosing. We're going to border mold inside of that record base. Take our final impression, border mold again, Then we measure our vertical dimension of occlusion, and then we get our centric relation record. So always final impression, then you do your measurements for vertical and horizontal. After you've done your impression and your records, you scan those. Same protocol as we showed before. It can go into the benchtop scanner, intraoral scanner, or CT scan. Most common, again, the benchtop scanner is what your dental laboratory is going to have. You might have an iOS in-house, and you can just use your wand scanner, scan the impression, scan the bite, scan the wax rim, and then everything will get pulled together in the software. So this is a case where I took my digital wax rims, we did our impression, we did our bite, I stuck them in the scanner, and it digitally beads, box, and pours for you. So you don't have to pour your final impression ever, you just scan your final impression. And then up here, now we can move this around and see where everything was that we marked. And I love this image because you can see where I marked the high smile line, and you can see where I marked the patient's midline. And now that's preserved throughout the entire design process. So then when the lab starts to do their tooth arrangement, I can make sure that they actually lined up the denture tooth arrangement with where I marked the high smile and midline. And here you can appreciate where the ridges are. You can see the digital land area, which I think is so cool. So these are the casts, the master casts that are generated from that scan. And you'll see they're preserved at the vertical dimension and the centric relation that we established with the wax rim. So again, another image just showing that you can see where the midline's marked, you can see where the canine lines are marked. That all stays in the software. So when you ask your lab for your digital preview, you can make sure that the teeth are in line with that. The softwares today are so smart and so fast. So whenever you pull this digital master cast and the digital interocclusal record into your software, you pick certain landmarks depending on the program you're using. It's usually retromolar pad, incisive papilla, tuberosity, and the software says, oh, then this is where the teeth go. This is all based on the evidence base that we've been using since the early 1900s. We want the anterior teeth 7 to 9 millimeters from the incisive papilla. We want the mandibular teeth directly over the crest of the ridge, 2/3 the retromolar pad, et cetera, et cetera. Everything that was in your textbook is now in a computer, and it just populates it like that. And this is what the lab gets. And then they can customize it from there. So they can take out a premolar, they can drop the second molar, they can add some crowding if you want something more natural. They can make the teeth custom to your patient, so they can give you a wider central or a smaller lateral. They can add wear, whatever you want to do, that can get customized from there. Something that's really nice about digital dentures is that the posterior teeth are locked in together at that ideal occlusion. And so when the molds were designed, they were designed to fit in an ideal occlusion. And normally with wax teeth, once you move one tooth, you have to move all the others to match it. On this one, you can move them all as a unit. So you can change their curvicity or move the plane of occlusion or move it buccally or lingually, and that interdigitation doesn't change. From our wax rim and our digital preview, we go to our monolithic try-in, same workflow as before. Follow your checklist, grind on it if it's bad, don't grind on it if it's good. We can do a wash impression again to try to stabilize the base if you don't have a great fit. My new favorite dental instrument is a Sharpie. So I can draw where I want my gum line or where I want my midline or incisal edge. We could do any occlusal adjustments you want, so you can grind like crazy if it's way off. I usually advise taking a new interocclusal record or Regisil bite. If that's, no matter what you do, if you make any changes, it's always nice just to get that fresh bite for your dental laboratory. So that, I know I flew through that wax rim. I'm trying to teach you everything in an hour like I do with my dental students. If you want a more in-depth review of the wax rim workflow, again, this is a video that is on YouTube. It goes step by step through the wax rim in a lot more detail. If you want to try a different workflow, the first one we taught with our dental students was the Wagner workflow. So this is another proprietary workflow. This one's really nice because the Wagner try-in has the anterior teeth individually in wax, so you can move them one at a time. So it kind of gives you some of that tactile sense that we love as dentists and prosthodontists of moving those teeth in wax and getting that physical feel. There's wax blocks in the posterior, so you can use conventional MMR techniques. And so if you look up Wagner workflow, it'll walk you through all these steps. It's typically a 3-appointment workflow. You can add a monolithic try-in between steps 2 and 3 if you need a little bit more posterior verification. And this is showing the Wagner try-ins. And you can see that the teeth are all set in wax on the top. The denture bases are printed. They are a replica of what the final denture base will feel like. That's another wonderful benefit of digital dentures that isn't always talked about, is at the try-in appointment, you know if your final denture is going to fit. So if you think about one of the most terrifying moments of complete dentures is when you deliver that maxillary denture and then you ask your patient to smile and you just pray that the denture doesn't fall right back out of their mouth. That doesn't happen with digital dentures as often because you know at that try-in appointment if you have retention or not. So you get a second chance to gain retention and boardable if you need to. DentCut is one of the very first workflows that ever came out for digital dentures. This is how I learned how to make digital dentures. It's another 3-appointment workflow. Technically, you can skip the monolithic try-in. I've never been that bold and do it as a 2-appointment workflow. But they have these customized trays where you can set the vertical dimension and get your CR at that first appointment. And there's a lot of, if you visit the Dentco website, that will take you there and kind of walk you through that workflow. So now we talked about patients that come in with no teeth, and we've covered 2/3 of the patients. What about those that have a terminal dentition that need an immediate denture? This is my immediate denture checklist, my flowchart. If you want to take a screenshot, please feel free. If not, you can email NDX. I'm happy to share this. I have it handy that I'm happy to share with anybody. I feel like I want to share all my knowledge with the world. So what's mine is yours. But this will walk you through kind of a yes or no checklist on the steps you can take on developing your immediate denture. For almost all digital dentures, we are still starting with conventional impressions, whether they're dentate, whether it's a reference denture and you're taking an impression inside, or whether it's an immediate. Usually we start with conventional impressions. That said, you certainly can start with a scan. Now we'll talk about that in just a few minutes. This case, the patient was already in a partial denture. They had a lot of missing teeth. We were having a difficult time getting the scanner in, so we chose to do conventional records. We took alginate impressions. We did wax rims conventionally. And so we had actual physical models. That all got scanned in, and then we jump into the digital workflow. And I'd like to show this because it shows how you can jump from conventional into the digital world. So if you don't have an intraoral scanner or you don't have a benchtop scanner in-house, this is a nice way. You take your alginate, send them to the lab, and then they can scan everything in, and you can still capitalize on the benefits of the digital denture product and the communication and preservation of records. So this case, we did a partial monolithic try-in. Basically, the complete digital denture is designed and printed, and then they grind out the teeth that are still present so that we can try in the front teeth. Because this patient was missing all their front teeth. So if we do a partial denture try-in, we can confirm that our incisal edge position, midline, incisal plane, fricative sounds are all well established before we go into the final denture. This is the case that Ibrahim Dukam worked on, and so he and I kind of wrote up this case together. He's going to be presenting for NDX next month, so I hope you get to see him too. He's a fantastic speaker, an amazing person, an amazing dad, and a really good friend of mine, outstanding speaker, so I hope you get to hear him too. This case, the patient had a really steep V-shaped palate. You can appreciate in the design on the left, so we wanted to do printed so that we could really recreate that anatomy in the final denture. And so what you're seeing on the left is our digital preview. So the lab sent us these pictures to make sure that we were happy with the tooth placement before they printed the final. And this was the final at the time of insertion. And so this was the day of surgery. Dr. Dukem did the surgery. Denture was delivered, and this was taken immediately post-surgery. If you want to learn more about this workflow, again, very short time. I'm throwing a bunch of words and workflows at you. This will take you to Lab Management Today, which is a dental magazine that it is a totally free magazine, but you have to log in with an account. So you can log in and see that one as well. That said, digital is also becoming more and more popular. And I think that a lot of immediate cases I will do digitally because the teeth are a little mobile or they're periodontally involved and we don't feel great about impressions. Lucio LaRusso wrote this fantastic paper on scan patterns. And it's available again for free online, 3Shape website. So if you go to the 3Shape website, look for Lucio LaRusso, you can find this paper that he wrote about intraoral scanning for complete dentures. And even if you're scanning, you still have to border mold somewhere. So I say border molding always happens. Sometimes it happens at the beginning, sometimes it happens at the end, but you always got to capture those borders. The scanners don't yet pick up the functional movement yet of the borders. And so this is the case that we did completely digitally. We scan the patient's terminal dentition. This is the digital preview that my lab sent back to me. So I'm double checking the incisal edge position, following the midline of tooth number 8 and making sure that they've made the changes I've asked before I give them the thumbs up. And this is our 3D printed denture the day of surgery. So this one's done totally digitally, intraoral scan, digital preview, measure the vertical and go that way. This case is made with a monolithic printed denture. So there's a new type of printing that is called jetting or FDM printing, where they're not printing the base and the teeth separately and bonding them together, but they're actually printing them all as one piece. Those printers are more similar in conceptually to an inkjet printer, where you have all the different colors that can come out at the same time. So you can actually print different shades of teeth. You could have every tooth in the denture a different color and it's printed at the same time, which I think is so cool. So since we didn't border mold for this case, since we scanned, we pick up our border molding here at the reline. So we do a co-soft, co-comfort, Linol, silicone reline, GC, Tokiyama, whatever you like. You do a reline and then you border mold, or you send your patient home to function with it and they do a functional border mold for you. But you're still picking up the borders here. I have learned that you can reline pretty much any resin, whether it's printed, milled, whatever, as long as you get it dry. And so I had like 4 different printed dentures out of 4 different materials, and I used 4 different relines, and they all matched together. All I had to do was get the bases super, super dry. So if you want to learn the digital immediate denture workflow, this is an article that I wrote with Dentistry today. Again, free article. You might have to sign in. I don't know. But it's a free article walking through digital immediate dentures and kind of how I read the digital preview and how we copied the case. My new favorite workflow, I do intraoral scan, design, make the printed denture this way. And then after they heal, I do the reference denture workflow, which I showed you first, to make their final denture. So I believe in an interim immediate that gets remade after healing. With digital and printing, that's become more cost effective and time effective for me than the conventional denture workflows that were immediates. So immediates, I say if you're a dentist that wants to get into digital dentures and you don't know where to start with your immediates. They're the least predictable, the hardest to communicate with the patient, the hardest to communicate with a lab. Going digital takes away some of that unpredictability. So if you're a dentist and you're like, I want to try digital, but I don't know where, do it for your immediate. So that was so many different things that I told you so fast. I hope that you found a great workflow that you can take into your practice tomorrow or whenever your next Edentulous patient comes in or terminal dentition patient comes in. I really appreciate your time. If I talked too fast, you can find me on Instagram at Dr. Wendy's World and send me a message, or you can reach out to NDX and they can forward any information that you have to me.
Thank you, Dr. Clark. You're always so engaging and open. Audience, we do hope you enjoyed the presentation as much as I did. And we do wish you to take care of those patients, and don't forget to tell us how we can take care of you in that survey that's popping up.